Hello Insta fam, it is Dr. T here coming to you on yet another wintry night here in Perth, and it's only going to get worse tomorrow, so I've been told. The local cross country competition has been cancelled, so it must be going to be really bad tomorrow. How are you guys? I hope you're really well on a Wednesday night. Yay, August tomorrow, last month of winter. I can't wait. I definitely have seasonal affective disorder. How about you guys? Every winter. I really think I should move somewhere where it is sunny all the year round. Righto. Well, why don't we drop some questions into the comments section. Again, let me just clarify our rules around our questions. Let's make them nice and broad. Not your whole life story. I will try to be as broad as I can with my answers for you. Yep, not a winter fan either. Me either. So drop your questions. I was sort of thinking, what sort of things could I chat about until the questions come through? What have I seen this week? Male factor. Let's have a wee little chat about male factor. Sometimes people think that if there is a problem with sperm, IVF or ICSI are just going to overcome it. And whilst in some cases that may be true, we do in the world of reproduction actually have an obligation to work up the male. And my philosophy is that often this is the first time we are going to have an opportunity to see the bloke because he never goes to his GP. So I think we're obliged, we need to make sure that we focus on the health and well-being of the bloke as well. And sperm can be that real canary in a coal mine. So an abnormal semen analysis can signify to us that there is something significant going on with a guy's health. So we really do have to consider what could be going on. So I just wanted to put that out there. If you have a bloke in your life and you're seeking fertility treatment and there is an abnormality to the sperm, please make sure that your fertility specialist is doing a full investigation to see why. Righto. Do we have questions? I'm sure I saw one come through. Burke Megan, what happens to an embryo if implantation fails? It just gets reabsorbed. So the cells themselves will stop dividing. When an embryo is fertilized, we're basically starting from the 2 cells and then it divides 4 cells, 8 cells, compounds, all the way up to about 100 cells at day 5. And that's when you're starting to get that real differentiation of the inner cell mass and the trophectoderm. Now, at any point there, the embryo can just arrest. It can just stop dividing and the cells can start to degrade. That can even happen after implantation has occurred very early on. So you'll get a positive beta-HCG and then it'll just decline. But those cells, like many others in the body, will just get the degraded cells will just all kind of disintegrate. And then those immune cells, those natural killer cells and others will come around and kind of mop up all the debris. So yeah, your body kind of just reabsorbs it. Same thing is if you ovulate and that egg doesn't get fertilized by sperm, what happens to it? It just kind of collapses and then the debris gets reabsorbed into the body by the immune cells. So it's really cool, huh? We're good at recycling materials. We're not very good at preserving, but we're good at recycling. Any other questions? I love that question. That's a really thoughtful question, actually. What happens to the embryo when the pregnancy doesn't continue? Any other questions? So I'll go back to my male factor thing. So I had a bloke come and see me with no sperm. And what we actually figured out was the hormones that his pituitary gland producing, so FSH and LH, just like in a female, weren't being produced due to, genetic factors in his brain. So in fact, he had never gone through puberty. He had to have puberty induced when he was a young man. And he was put onto testosterone therapy, obviously to induce puberty, but also to help him maintain his vitality. And unfortunately, exogenous testosterone tanks the sperm count. So when he came to see me, I had to put him on, so he came with no sperm count, but we've put him on gonal F, recombinant FSH, and we've also put him on Ovidril, which is recombinant HCG, and the purpose is to kind of reignite spermatogenesis. And in guys who have this hypogonadism, it will often take months, sometimes even years, to generate sperm. So you've got to be really, really patient with this stuff. But you can see that it's not all about just doing IVF. We can use the similar kinds of hormones that we give women to go through IVF. We can give them to men as well to induce spermatogenesis. So I'm just sitting here whilst I'm doing this little live with you, and my puppy dog is completely destroying my house. So we are going to have to move forward quickly through these questions. Babicuri. Can a sperm analysis show low count because the men didn't collect the sample? Yes, and often they'll have a low volume as well, or just a small amount of sperm could be enough for the test. So if they have missed the cup, which happens because the cup's pretty small, not only will the numbers be low, but the volume will be low. So often if the volume's low and the numbers are low, the concentration, that's why we look at the concentration as well as the count. They're two different measures. So the concentration will tell us how many sperm per mil, and if you've got a low a low volume, the concentration could be normal. And then it will also tell us about the count. Equally, you can have an abnormal concentration, but a completely normal count if the semen volume is high, because the semen itself is not made out of products from the testis itself. It's made up of things, so secretions from the seminal vesicles and even the prostate, which is further down the reproductive path. So they are quite independent, and that's why we need to consider both the count and also the concentration when we are looking at semen analysis. So that's a really good question, but yeah, we certainly consider that. Life of Brit, what happens in an IVF cycle when the person's normal cycle is long and delayed ovulation? Do the IVF drugs make the cycle normal? Yes, it does make sense. So yes, we perform IVF on women who have, say, ovulatory dysfunction, say, due to PCOS, who might have 40, 60-day cycles. It won't take us 40 to 60 days to stimulate ovulation in an IVF cycle in those women, because we're giving higher amounts of follicle-stimulating hormone to stimulate follicle growth. Whereas often in PCOS, it's an abnormal signalling from the brain. So the brain gives this kind of pulsatile release of FSH and LH in certain amplitudes and frequencies, and the ovary in a coordinated fashion then releases just one follicle. Whereas we're kind of hitting a nail with a sledgehammer by just giving you lots of it and making all of these follicles grow up at the same time. So that will happen within a much smaller period of time. Often within sort of 12 to 14 days, we'll be able to get to the point where we can trigger ovulation. So yes, we can kind of normalize the length of the cycle by just banging it with a hammer, so to speak. Gosh, I hope that doesn't get out there virally that we're just banging ovaries with hammers. Skip 11. How many cycles should someone... Oh my goodness, now my dog's emptying the bin. How many cycles should someone wait post-OHSS before frozen embryo transfer? Well, you really need to get well. That's the big one, because ovarian hyperstimulation syndrome is a cluster of symptoms. So, your third spacing fluid into the tummy, sometimes into the lungs, sometimes around the heart if it's really severe. And that will make you quite breathless, sore tummy, nausea, vomiting. Sometimes it can cause, significant renal compromise. So you have to be well before you would do an FET. Often you can get well within a couple of weeks. And so it might be that you have a month off after your IVF cycle, allow the symptoms to decline and an ovulatory cycle to get back to normal, and then you would do a frozen embryo transfer cycle. So I think that's really important. But yeah, making sure you are symptom free. Now that's sometimes when people get late onset OHSS when they're actually pregnant, it can take weeks to months to get better because the pregnancy is ongoing and the HCG from the pregnancy is kind of supporting the OHSS symptoms. So it can take much longer to recover from late onset OHSS due to pregnancy than OHSS that happens after a stimulated cycle. So yeah, that's a really good question. Any others here? Any other questions? Oh gosh, now the dog has disappeared. I'm not quite sure where he's gone. I'm actually quite worried. He's been 9 months. I tell ya, it's worse than a baby. Gosh, he is really like tearing my house apart. I don't think there are any more questions that I can see. Let me run all the way through to the end. Does anyone else have any questions about IVF, about reproductive medicine, about menopause, about pediatric adolescent gynae, anything at all? What breed? Oh, not a Staffy, Mama Staffy. He's a groodle. Yep. So apparently, as I've found out, they are all amounts of crazy, and it's both the golden retriever bit, but also the poodle bit. So I've got 2 times the crazy going on right now. But he's very smart. He knows how to open doors, handles like that. He can open doors. He knows how to open drawers. So he grabs the drawer handle with his teeth and opens the drawers. He's a smart dog. Thoughts on RIF, recurrent implantation failure, 8th failed transfer. Oh gosh. So I would always kind of just put a hold on things after a 3rd failed transfer. And that's of embryos that are blastocysts, so extended culture, day 5, day 6. I don't believe in day 3 transfers. So, if you've not had success after transfer number 3, you've really got to grind things to a halt and go back to the drawing board and really consider what could be going on. So 50% of implantation failure is probably due to chromosomal abnormalities in the embryo itself. 50% is due to a whole heap of other things. I would always consider anatomy, so looking for polyps, for fibroids, looking at endometrial thickness, perhaps considering adenomyosis, considering endometriosis. Do we need to do a diagnostic laparoscopy, or if they've got obvious disease, do we just need to downregulate them with hormones before a transfer? I would look at endocrine factors, prolactins, thyroids, sugars, insulin resistance, look at weight, anything that might impact on metabolics of the body and sort of that environment. I'd be looking at clotting abnormalities, so thrombophilias, particularly things like antiphospholipid syndrome. Gosh, I feel like I'm answering an exam question right now. I would be considering male factor, so looking at DNA fragmentation in the sperm as an impact on quality of the embryo. And then there's all the weird and wonderful stuff, so the autoimmune stuff, which is really much further down the pathway because the evidence around this stuff is really quite vague. But chronic endometritis, I might do an endometrial sample looking at, is there grumbly infection, or do hysteroscopy to look at the features of the cavity itself, which might signify chronic endometritis. Yes, I've been known to do uterine natural killer cells, but more often than not, they come back completely normal. So if you're at your 8th transfer and you haven't had those things done, feel free to kind of just put a hold on things and let your fertility specialist go to town. Many times we don't find anything, and it's often extremely frustrating. But I would absolutely be ensuring that you've had chromosomal analysis of your embryos before you transfer anymore, because transfers are disheartening, they're burdensome, they're costly, they're time consuming. If you've done more than 3, you want to make sure that the next one that you're putting into your cavity is actually chromosomally normal. Otherwise, that question is just, it's not being answered. So hopefully that's helpful. La Pipita. What are some signs of perimenopause? Is menopause age on our mums a reference? Yeah, look, it kind of is. So if you've got a family history of an early menopause under 45, then, there are some familial trends that happen there. So menopause, the definition of menopause is 12 months no period And so it's kind of a retrospective diagnosis. Oh, look, I haven't had my period for 12 months and I've got these menopausal symptoms. Really, the time that we're most interested in is the perimenopause, because that's the time when you're going to go, what is happening to me? What is this mood thing? What about this 4 kilos that I've gained? Why am I sort of sticking my foot out of the bed at night time? Why do I hate my husband? Like there's all this range of perimenopausal symptoms that you're experiencing that you don't know what to attribute to because your periods are still happening. And then you get dysfunctional bleeding. So often you will have shorter and shorter periods down to 21 days between, and then you might go a couple of months without one, and then you might have a little bit of weird bleeding, and then you might go another couple of months without one. So you get this really dysfunctional uterine bleeding. Combine that with these perimenopausal symptoms, that's the transition. And that's the time when I get a lot of patients coming to see me saying, what is going on, Tamara? And that's often when I'm having a discussion around menopause hormone therapy. So there's some of the signs of perimenopause. All right, a couple more questions. Ensukik, what are the general success rates leading to a healthy pregnancy after a miscarriage, and how soon after a miscarriage can you try to conceive again? It's a little bit of a grey zone. But the general success rates after a miscarriage are good. So you are more likely to have an ongoing pregnancy after a miscarriage than you are to have another miscarriage. The number of people that have a miscarriage anytime in their life, about 25%, drops down to about 10% with 2 in a row, and drops down to about 1% with 3 in a row. So at 2 in a row, 90% of the time you're going to have an ongoing pregnancy. So the stats are pretty good. There's not really any hard and fast evidence to say you can't try and conceive after a miscarriage, but generally I suggest to patients that if you've had a miscarriage, perhaps wait a cycle for the lining to regenerate and the ovulatory cycle to kick back in before you try to conceive again. So often just leaving it a cycle is adequate. Laura Jane, 89, how quickly does endo recur? Removed a few months before a pregnancy. Is it likely to come back between pregnancies? Yeah, so great that you feel pregnant after your endo was surgically removed. That's often what we predict, certainly for minimal and mild disease, is that it improves your pregnancy rates after a section for 6 months. Once your cycle returns after a pregnancy, it's really on your doctors to say, hey, you probably want to crack on or suppress this to prevent the disease coming back, because it will. And although I don't have any hard and fast rules about this, if you've had a good 6 months worth of cycles, it's reasonable to think that you're going to have an appreciable amount of disease coming back. So it's my advice, if someone has had endo, their cycles have returned, they're not planning on getting pregnant straight away, hence you're going to need contraception anyway, get yourself onto some progesterone only if you're breastfeeding. Progesterone only hormonal contraception, which we know will suppress the development of endo. It then will improve when you're ready to have your next pregnancy. It then will improve your chances of conceiving. Funny that. So that's how I would normally play it. How I play it with my IVF patients is get on contraception while you're breastfeeding and your period hasn't returned. Stay on that contraception, and as soon as you're ready to have a baby, we'll stop that contraception and put an embryo back in. So there's no chance for that endo to come back and cause havoc with our embryo transfer in the future. All right. I think I'm going to wrap it up, guys. Not bad. Some pretty good questions there. I'm pretty happy with that. I hope you guys have been happy with the answers. Thank you for jumping on. I'm going to see you this time next week. We'll be into August and we'll be having the rundown to spring. Can't wait. Have a good night. See ya.